Hi, this is Dr. Milind Chaudhary. Welcome to this talk on post-operative care of the Ilizarov Fixator and the Ilizarov techniques. The essential difference that we need to know between any other operative procedure like that of arthroscopy, arthroplasty, or internal fixation in the treatment of fractures versus the Ilizarov techniques is that the Ilizarov techniques are not a single operation. They are a procedure. It is a procedure in which the operation merely marks the beginning of the procedure. So only 10 to 20% of the job is done at the time of surgery, and 80 to 90% of the task remains to be done as a procedure which may last from 3 to 9 months or sometimes maybe more. A friend of mine once famously said that the Ilizarov techniques have made me the richest man in the region. So before the young surgeons decide that they start dreaming about these wonderful logos, and especially the one on the top with the circles, I need to remind them with a caveat that what they really need to do if they want to master the Ilizarov techniques and if they want their patients and themselves to benefit from it is that these 5 rings which represent the Olympic logo more or less are accurate in determining the amount of effort that's needed, perhaps, to make the Ilizarov technique succeed, especially in the beginning. The pen might be mightier than the sword, as they say. However, for the relief and control of pain after the application of the Ilizarov fixator, the pen is not mightier than the spanners. And therefore, I exhort you young surgeons to take spanners in your hand and not take the pen in your hand to prescribe analgesics or painkillers or injection diclofenac in the post-operative period. You need to use spanners. If in the post-operative phase, as is our protocol, on the evening of the surgery, we go to the bedside and make sure that all the connections of the Ilizarov fixator are tightened. You can see this young orthopedic surgeon, a fellow of mine, who is bending down to do the tightening in this manner, or in the outpatients department, bending down to do the tightening and frame maintenance. You're likely to feel that this is a tiring and unending task, much like the myth of Sisyphus, in which Sisyphus is this mythical Greek giant in this story where he is condemned by the gods to roll up a huge boulder up a hill, only to watch it come rolling down immediately thereafter, and he has to again climb up the hill with the boulder. Hence, in a sense, it's like an endless task. So therefore, to get rid of this notion, one needs to engage in ergonomics. If one is at the bedside of the patient, one can put a knee on the bed to break the strain on the lumbar spine and perform the tasks of routine frame maintenance. Or if you have adjustable bed heights in the outpatients in the follow-up period, then you can work on the patient, modify the fixator, change the struts, do the necessary things, add hinges, etc., without breaking your back. Now, the Ilizarov apparatus is very famous because it gives us a 3-dimensional control over all aspects of the limb, and we are able to control 3-dimensional deformities. The great Professor Ilizarov also gave us the ability to control the 4th dimension, that is time. That is, we are able to improve things over time, lengthening takes place over time, gradual deformity correction takes place over time, which can be a boon in the treatment of severe deformities which may result in neurological deficit. However, the very same fourth dimension can also be a bane and not just a boon. That is, things can deteriorate over a period of time with the Ilizarov fixator, and one has to be watchful for problems. Because, as I said in the beginning, it is a process, and one has to monitor the entire process from the beginning till the end, which may be several months coming. Therefore, in this process, Murphy's laws apply very much. That is, whatever can go wrong will go wrong. And hence, we must be aware of this and keep our eye out for problems. There are 3 things that I advise young surgeons. You need to create a place for the follow-up, for this process to take place properly. You need to designate a place, a particular OPD. You need to create a team which consists of the radiology technician, which consists of the assistants who will modify and maintain the frame. You need to have nurses who will do the dressings, and you need to have people who help the patients schedule, etc. It's not enough for the patient to walk into your consulting chamber every time, because the one question they inevitably and only inevitably ask is, when is the frame going to come off? Hence, you need to create a team who understand the whole process and can counsel the patient and do the various tasks without burdening the surgeon himself in the post-operative phase. One of the first and most basic problems that we need to solve with the Ilizarov techniques is that of axial deviation in the post-operative phase. In a young patient like this who has post-traumatic deformity, the distal femur lengthening, you can see the distal fragment has gone into varus and is medially translated. And despite efforts, the correct amount of the translation is not achieved in post-operative phase, which however could be achieved once we made the struts parallel to the bony segments and allowed us to get this correction. On the right is this full length X-ray which shows that the overall axis of the limb is now aligned after limb lengthening is done. So the accurate placement of hinges, taking X-rays in the post-operative phase with a joint above and joint below clearly visible, is one of the prerequisites of understanding the extent of axial deviation and taking. Another example is this very typical proximal femur lengthening in post-traumatic reconstruction in a femoral non-union. In patients like these, if we use an LRS fixator, it is inevitable that there is varus as well as medial translation. What is also happening in this patient is that the pins are losing their grip in the proximal fragment, and hence we need to take action. And this is what we did. We replaced those pins with the help of pins inserted along the neck as well as from the greater to the lesser trochanter, which solved the problem in a configuration that looks like the hash. So this is called the hash configuration. And this is very strong, and it allows us to correct the axial deviation and get the distal fragment aligned to the proximal as well as correct the varus deformity. Similarly, in the tibial lengthenings, proximal tibial lengthenings, which are very common, the procurvatum deformity is a very common one to arise because of tightness of the gastrocsoleus complex and because of the way in which the patients sit. And to be able to detect this deformity, it is necessary to have an X-ray which also includes the knee joint. When that is done, we are able to then add hinges and correct the deformity. Sometimes it becomes necessary for us to also change the orientation of the proximal ring, because more of posterior distraction will lead to the ring posteriorly touching the thigh. And then we need to change the ring, put in a temporary ring like so, and then get a new one which is oriented with its distal part posteriorly, which is much more angled distally to allow us to correct the procurvatum. So this is the position I wanted to show you. This is the position in which patients sit. They sometimes put the non-operated leg under the knee of the operated side for comfort, and then it becomes a contracture. And then when we try to straighten it, the proximal fragment goes into procurvatum. Premature consolidation is another problem which is commonly faced, especially in younger patients and surprisingly in adults in proximal femur lengthening. These are examples I have shown wherein there is premature consolidation of the proximal femur lengthening, not once but sometimes twice or even. There are many reasons for premature consolidation. One of them can be the very good muscle cover of the proximal femur itself, the fact that sometimes these lengthenings require a much higher rate of distraction than we are willing to give. Some other technical reasons could be that the struts that are responsible for the lengthening are not aligned parallel to the axis of the bone, and one has to be watchful and one has to increase the rate of distraction or end up performing a repeat corticotomy, as we have had to do in these cases. The poor regenerate formation, fortunately for us, has been less of a problem, but can occur from time to time and result in a very significant delay in the fixate removal. This lady who had an infected non-union of the femur, which was treated initially with debridement and antibiotic rods, went on to get compression at the non-union and lengthening in the proximal femur. As you can see on the X-ray on the right, there is very poor bone formation because during 1 month that she went home, she distracted at an excessive rate of more than 3 to 4 millimeters per day rather than only 1 millimeter per day. And you can see no bone formation. So you can see that we have performed the accordion maneuver in which we have gone back and come forward again at a slow rate in order to stimulate the regenerate formation, and it has solved the problem with a little bit of varus deformation. But this varus has, because of the valgus deformation that's present at the lower end in the non-union side, the accordion maneuver helped us to solve the problem of poor regenerate. Now, irregular defects of the bone can be present, which can present specific challenges. This is another non-union of the femur in which there is a defect in the medial end. Were we to resect the ends of the non-union to get perfect coaptation of the fragments, we would create a large defect which would necessitate a lengthening, which this patient did not want, and he did not want to come for routine follow-ups. So we can solve this problem in irregular defects by performing compression at the non-union side at a very slow rate which does not exceed 1 millimeter over a point. And this can allow the fragments to heal up without going into axial deviation. Another example is that in the tibia, in which this patient has had a failed non-union treatment with the Ilizarov method in the past. We redid the debrima and then went on to reapply the Ilizarov Fixator, in which we applied the compression at a nominal rate which allowed him to unite without going into axial deviation. Dissection and lengthening, of course, can be performed from time to time when there are irregular defects, as in this young man who had this middle tibial defect, and we resected the entire bad bone and lengthened from a proximal side to solve the problem. The issue is when to ignore shortening. When can we ignore the shortening and go ahead to perform compression? Well, this is a young man who had a brachial plexus injury with a non-union of the tibia. Were we to perform lengthening, he would not be able to walk because one limb is almost completely useless, though he has undergone surgery for its repair. So we chose to perform only compression. This allowed him to walk full weight bearing on the limb without using walking aids and helped him to solve the problem. And here he is 18 years down the line with a solidly united tibia with no desire whatsoever to get the lengthening done because he's getting along just fine as a street food vendor without any problems with a shoe raise. Now, specific strategies that we employ to assure union in difficult cases may be the use of horizontal compression. This young gentleman is actually a neurologist in training in Russia who has a supracondylar non-union of the femur which has been operated multiple number of times, but he has simply not united. He came to us like this with these x-rays showing a very low supracondylar non-union with a large cement block and just poor fixation with K wires. Multiple episodes that healing had failed, probably because the surgeons could not appreciate the havoc that's being wreaked by the oblique non-union surfaces. So what we did was, we did a proximal lengthening, of course, to overcome the shortening, and with the help of the TSF fixator, we set up a horizontal compression, that is, compression perpendicular to the non-union surfaces rather than in a proximo-distal direction or a vertical direction. We set up a side-to-side compression which allowed the distal fragment to be translated at a minimum rate anteriorly to enable union to occur at the non-union surfaces like so. And he went on to unite very well, and he has resumed his postgraduate residency in Russia in the city of Kazan and sent us a video of him dancing on the street during a festival, and he's absolutely fine. So horizontal compression can save the day, it can prevent shortening and ensure early healing. Now, the stability of the frame and its assessment during the post-operative phase remains a key issue to be solved and one of the most commonly needed tasks. This young lady with significant humeral shortening had her lengthening done with the help of the LRS fixator. As you can see, everything went well, but over a period of time, as you can see on the X-ray on the left, we added a pin to improve the stability of the fixator, and she went on to get all of her 14 centimeters of lengthening, which is almost 97% length, and retained her function fully in the elbow joint without problems. and the stability helped in early recovery of range of motion. So far, I have been explaining to you the tasks that need to be done during the post-operative phase to ensure smooth sailing or a smooth completion or an early completion of the process. However, now we go on to the need for preparatory surgery in specific cases. This is a young girl who came to us from Qatar who had a congenital short femur, but she also happened to have acetabular dysplasia, for which in the first stage we performed a DEGA to ensure that the acetabulum was not dysplastic, and then went on to go ahead with tibia lengthening and then femur lengthening in the second stage. And as you can see, she has full range of motion of the knee and the hip is very nicely contained without problems. And she went on to get a third lengthening at the age of 15 years, close to skeletal maturity. And in so doing, we did all the lengthening without any problems. So the key was to perform preparatory surgery for the acetabulum in time to prevent dislocation and subluxation, as can be gleaned from many references in the literature which speak about hip dislocations with lengthening. So here she is, and of course a very important thing in the post-operative phase in femur lengthenings or tibia lengthenings in the congenital cases is to do elastic rodding at the end of the procedure. That's after, at the time of removal of the apparatus, we should scoop out the pin tracks as well as insert the rush nails or titanium elastic nails to ensure that uh, there is very good the rate of refractures drops to nil at the end of lengthening if we use these very simple titanium elastic rods or rush nails to protect the regenerate with the 3-point pressure. Similarly, the thing to note about lengthening is taking the decision about how much to lengthen. This is another child with congenital short femur in which we have used the Ilizarov Fixator to lengthen. And though the patient seems to get very good bone formation and the parents are keen and desirous of getting more and more length, one should not give in to the temptation of lengthening more, which can give rise to problems. So as they say in Hindi, lalach buri bala hai, that is, greed is a big sin and one should not fall prey to greed, the greed or the desire to achieve more length, because that can help you to get a good result and preserve the knee and hip range of motion, which is so very crucial to patients' function. Of course, one of the very important things to take care of in the postoperative phase is nutritional status of the patient. This is the story of a young lad from Bundelkhand who came to us with this large gap in the tibia, the non-union, and his treatment went on very slow. His parameters, as you can see, were very bad. He had a very significant non-union with infection. We debrided, we put him in the Ilizarov Fixator. The bone transport progressed, but final healing of the non-union really took a very long time. Surprisingly, during follow-up visit, we found that he just completely healed over a period of 1.5 months. And he used to be asthenic and thin. And I asked him, what was the secret of his success? What changed overnight? And he said that my mother purchased a buffalo just for me so that I could drink several liters of milk every day. So grass-fed buffaloes and high-quality milk with all its protein and fat improved his nourishment so dramatically that he just went on to unite. And this is a story that has played out time and again in my practice, especially amongst young employed women who are unmarried in their mid or late 20s, who suffer from non-unions or who need lengthening and deformity correction. And due to poor nutrition and their fussiness, they heal really slowly because they have very poor hemoglobin and vitamin D levels, as well as very poor intake of nutrients. So one has to pay attention to these things. And a very crucial component of post-operative care is ensuring that our patients are back at their employment, go back to work, unless and until we tell them they choose not to do so. This is exemplified in the story of this young orthopedic surgeon who had a non-union of the tibia for more than a year. He came to us and we put him in the all-wire Ilizarov frame to get him to compress and unite with a fibulectomy. He was doing well, but within a few weeks, I realized he needed to be back at work, and surely he gained, he spent his time very fruitfully working as a fellow with us for all the 7 months that the fixator was on his leg. So never for a day he felt that he was handicapped, that he was hamstrung, that he was not being fruitful. So he was, he had gainful employment, he was learning some things, And so therefore the treatment went on smoothly and it took his mind off the treatment, which is what I recommend to each and every one of my patients, that they must resume their employment and not sit. It's very important that your patients who've got a frame on their leg don't sit at home moping around, out of touch with the world, out of touch with their offices or their employment situation, or out of touch with their fields or whatever work they may be doing. If they resume work, they will heal quickly. So he went on to heal, and he's a very successful orthopedic surgeon doing really well in life now. So um, perhaps it would be not inappropriate. So after all these admonitions and warnings that I have been giving you, I want to leave you with a very reassuring thought that came to us from none other than the great Salvador Dali, who said, have no fear of perfection because you will never reach. So the crux of the matter in dealing with the Ilizarov Fixator in the post-operative period is to be alert, is to look for problems, and to solve them as they come. Because, as somebody very famously said, the price of liberty is eternal vigilance. The price of freedom from complications in the Ilizarov method is eternal vigilance to what is happening in the fixator at all times. And like the great Professor Ilizarov said, if you do